Welcome, everybody. We'll start our first panel of the day. And my name is Shahid Shah, in case you're appearing here today and you weren't here yesterday. So I'll be moderating most of the panels today. But really, my job is to just get these guys to introduce themselves. We're talking in this particular panel about privacy, cybersecurity, et cetera. But so much of that, it depends on a lot of other factors. And so we'll get into all of that. So Rob, introductions, and then we'll go down this path.
Great. Good morning, everybody. Thanks for having me. And I'm really looking forward to this, to be honest with you. My name is Rob Seabaugh. I am a healthcare strategist at SailPoint. SailPoint's an identity security company. I focus a lot on helping organizations understand the value of identity and why this really matters to the cyber protection and the value of your organization. But prior, I've spent about 20 years in enterprise IT and was a senior leader for a similar type role for a large healthcare organization. So happy to be here. Thank you.
Hi, good morning. Can you hear me? Good morning, everyone. I am Inder Kohli. I am Chief Information Officer at Englewood Health, which is a health system right outside of Manhattan. We're a health network of over 100 locations and one large acute care hospital. My role involves overseeing all aspects of IT, biomedical engineering, and unified communications. In addition, definitely a role overseeing all aspects of cybersecurity, digital, and AI. And I'm happy to be here and happy to join back again.
Hi, I'm Pam Secha. I'm the CEO of Elite Groups. Prior to being a CEO of Elite Groups, I spent 28 years in the healthcare provider space. I'm very happy to be here. In my past experience provider side as a CIO, I worked with a lot of amazing CISOs developing programs around cybersecurity, supporting the organizations. In my current role as the CEO, we work with a lot of healthcare organizations across their EHR efforts, as well as their IT infrastructure and enterprise IT strategy and initiatives. Thank you for having me here.
And I'm Stephanie Hines. I'm the CIO for Valleywise Health. So it's a safety net healthcare system in Phoenix, Arizona, so Maricopa County, acute care, behavioral health care, inpatient and outpatient, and 10 FQHCs. So I have responsibility for essentially everything that you do, including biomed and the AI functions that we're getting ready to deploy, in addition to the EMR, revenue cycle, business systems, cyber infrastructure. So happy to be here.
So welcome, everybody. And remember that you can pop open questions as early in the panel as you'd like. Just raise your hand and I'll call on you. But what I wanted to start with is, Rob, tell us, as you're having conversations with your medium to large size customers, what are their top 2 or 3 priorities when they're asking you to help with identity, with cybersecurity in general? And then how does that differ from the smaller ones? Right. Yeah. So they're not all the same. And we kind of like lump we just say healthcare as if that's one thing. Of course, everybody in this room knows that, small physician practices with 3 people in the office look very different than a large healthcare system. But there's a lot of commonality as well. So let's talk about maybe the medium to large commonality, and then we'll talk about the small.
Sure. So this role has really given me an opportunity to see healthcare globally. So I've supported the U.S. market primarily, but also Asia Pac, down in Brazil, other markets. And you start to see that the way we fund what we do may be different, but the challenges at the clinical floor really resonate the same, right? So one of the most common challenges we see is, hey, I'm a nurse in a hospital and I have to wear multiple hats, right? I might pick up a shift in another department because someone else is out on leave. I might float to different facilities a couple days a week. I might be a volunteer or a researcher. And in my world, that means more access for that person at any given time. And we have to think about, what does that look like when persisted? Stephanie and I were talking before this panel. You're all one click away from a ransomware event. Like it's really that simple. And so when we start thinking about the challenges we see that are unique in healthcare, it's this, this idea that, people are diverse. They've got again, these different roles and positions at the macro, health systems. A lot of them have the, funding, if you will, to support these large scale objectives. At the smaller health systems, we see a lot of homegrown, a lot of, things that, someone built 10 years ago and it hasn't been maintained, and that starts to increase risk, and we need to have an understanding of what people are doing. But at the end of the day, while we'll all talk cybersecurity, none of what we're doing should impede the efficiency of delivering care at the floor. Our goal is to be an enabler, and we have to find better ways to enable using modern technologies, that type of thing.
And would you see anything like that differing at the small scale, like where they use more cloud? They can't do on-premise kinds of stuff. So what does that look like for the smaller shops?
There's not, I wouldn't say there's a specific median that says the smaller scale organizations are going to be X and the larger ones are going to be Y. What we are seeing is, post COVID, and it's been a conversation this whole time, all day yesterday, the scale is changing. The walls are disappearing. We are seeing much more cloud and SaaS based adoption, because the ability to support and scale is huge, right? So if you're in a SaaS based disposition, depending upon the model of the organization or the software that you've chosen, when a vulnerability hits, you can scale and support fixing that relatively quickly across large sites, right? Versus if you're in a legacy disposition, it's thing by thing by thing that you're repairing, and it can take a long time and be very expensive, right? So we see a major trend in the industry in general heading towards cloud.
Got it. And Pam, so let's have you jump in also with a similar, you have dozens of customers at large scale, medium scale. What are you commonly being asked to focus on in terms of data privacy, data security, et cetera? And do you agree with the point that Rob made, that borderless doesn't necessarily change the nature of cybersecurity, but it does change the access points and things like that? So add on to that. And then what I'm going to basically do is to have the CIOs basically say, well, that's all great, but that doesn't matter to us. Here's what we care about. So yeah, tell us what you care about.
That's interesting. I just don't want to agree with Rob because I know Rob.
I got it.
But so my world is a little bit different than Rob's, right? Rob comes in a lot with offering the solutions, regarding the clients. I come from the other side, which is around workflows and operations. And so a lot of times when I come into organizations, and in fact, Rob and I are talking because we are partnering with some customers, because we do a lot of the operational components and the change management space, that sort of stuff. And so a lot of times when I come into organizations working with CIOs, whether it's academic health systems or safety net, FQHCs, it's always one thing people say, believe it or not, CIOs always say, Pam, I really love you, but can I do something? Can I get you connected with our CMO, our CNO, and our CEO and our COO group? Because we can do all the great technology that's out there and create the best framework and put in the best policies and procedures. But when a downtime happens and we're talking about recovery, we're talking about business continuity, we struggle with the operational alignment piece. So we come in a lot and we work a lot with operations, partnering with our IT organizations that engage us, and we work with the operational arenas to help them with their business continuity plans, which starts with your downtime policy and procedures, right? So we're teaching them how to adapt. When you see the BCA devices, they're identified this way. When it's unplanned downtime, how do you use these labels? How do you label this? How does it get to the lab department? How does it get to the medication? So we work a lot with them on developing policy and procedures. We help partner with the operations and IT group by bringing both of them together to look at alignment between the tier 1, tier 2 applications. What are some of the PHI sitting in those? What's the app rationalization? Because in many organizations, for example, Sutter Health was 11,000 applications, right, across the whole spectrum. And then you go to someone like New York City Health and Hospital, where I've served before, actually, they're like several thousand applications. And then you go to some of the safety net or smaller organizations, they're like 200 apps. So things we do with operations is bring them both together, look at app rationalization, and really focus on standardization. We need to get down to what our core systems, what our third-party systems we're going to be using, what are the integration points, what information's passing, so you have a diagram that shows what's going, where your vulnerabilities is on those cases. And then we work with operations and we do tabletop exercises. We have to do it on a quarterly basis because unplanned downtime can happen anytime. When it happens, most people do very well within the first 48, 72 hours of downtime. But when it goes past that, as you see on the news, some of the organizations stay down for weeks. That's when, from an operational standpoint with IT, you lose the stamina of how do you keep that ADT recovery going and stay on those downtime procedures. So we focus a lot on those components, is unplanned downtimes, your downtime policy and procedures, keeping it top of mind. So when it does happen, you're not like, I don't know what to do. So it's fresh, right? They know where their downtime policies and procedures is in one place. You can access it anytime, any day, and you're practicing it all the time. So you can actually do those. So I speak from a very different perspective than probably Robin, what I see, because I work a lot more with operationalizing how this is going to function together across IT and operations.
So for the CIOs now on the panel, it seems like we're relegated to the fact that we have to assume that whether it's a ransomware attack or a breach is going to occur, period. Now, here's how we prepare for the inevitable. Is that where you guys are sitting as well? Is that you feel that it's inevitable, which certainly in my work that I do with both governments as well as health systems, we just assume it's imminent and it's going to happen at some point. So what do you prepare? Is that how you think about it as well, or do you think about it differently?
I mean, absolutely. I mean, the last year I think is really indicative of what we can experience in healthcare, whether we're directly impacted or it's a partner. And I think for me, looking at who those partners are critical because, evidence has shown we are going to be impacted in some fashion. I think, the business continuity aspects are so important in the planning. I'm going to get questions from my board, and I'm 100 days into my role, so I'm actually preparing a deck right now for my board, but I'm going to get questions as to what's on the risk register. What are the things that are most likely to happen that are going to have, a pretty significant impact, and how are we preparing? So, to Rob's point, in the conversation we were having earlier, my people are my biggest, concern. How they are educated, how they're prepared, they're at the front line, to our organization. So, really making sure that we're focusing on that, but when it happens, not if, how they are prepared to be successful. So in my organization, we are a teaching hospital. So I've got a lot of residents. I have a lot of young physicians that have frankly never worked on paper. So, when you think about how do we prepare, you also have to think about what's the demographic of, your organization and what are their experiences. Because what some of us old folks who worked on paper clinically, and I am a clinician, we can go back to, this is how I did it. And I have a point of reference around what do I need to do to take care of my patient when I don't have access to systems. But I've got a whole group of folks that are like, oh my gosh, what do I do? I've never written a paper, order. I have no concept of what to pull on. So that changes business continuity practices, fundamentally. So those are things that I'm trying to think about. How do we prepare? How do we run those exercises? And, I think probably the last salient point I would make is we have to do a better job of creating partnerships between operations and IT, because we still have this mentality of, oh, cybersecurity, that's an IT thing. Oh, clinical operations is an operational thing. That's for clinicians. But really, we have a responsibility across both of those domains. And until we work as partners in that space, we're going to be challenged. And that, I think, is where the empathy comes in. When you're asking a clinician to do something that might not be the easiest way, but it's really relevant from a security perspective, you get that buy-in. And then also, too, having your IT team at the table in those preparation activities, really understanding what do I have to do to be successful in the middle of a crisis, and are we doing everything that we can, to make that easy on folks that are taking care of patients? And what's a challenged way? I mean, we've got really complex, high acuity folks that we're trying to take care of, and when you take those resources away, it's stressful for people. None of us want to not deliver good care or pose harm to a patient. And the fact of the matter is, when those systems are unavailable, that's a real threat.
Great points. And so how about at Englewood, you're thinking about it the same way, inevitable, but be prepared, or thinking differently?
So I'll answer by saying yes. We all know it's a matter of when, right? But I will go out on a limb and say, I don't think none of us are prepared, no matter what I say or what others say in terms of a preparation. But I'm going to weave everything which was mentioned earlier. So I'll pick on your point, Stephanie, about operation and IT alignment or operation and cybersecurity alignment. I think one of the, in my mind, the key point to understand is that cybersecurity is not CISO's role. It is definitely their role, absolutely their role. But from an organization perspective, um, organizations probably are not doing best service to them by cordoning it off under CISO. I think it's the CIO's role or CDIO, whoever is heading the operation end of IT, because CISOs are not very well liked by your infrastructure. No, it didn't let me by your infrastructure team, because all they do is create more work, yeah, and create hardships, right? And that is where a CIO needs to step in to create that alignment. And organizations always see that friction. Um, Second piece is, yes, we absolutely want to prepare in all possible ways, because cybersecurity, the ground floor of cybersecurity is what I think most of us have accomplished: blocking and tackling tools, maybe methodologies are all baked in. The second piece is the harder piece about organization processes, clinical impact, business impact. And that to me is, yes, we do all the tabletop exercise, but it's still very academic. It's still very documentation centric. It's process documentation. How will we react? So that is why I say I don't think we all are prepared. And again, I would say we value the input we all of our partners bring, because they do bring in expertise from across the institution. But no disrespect to anyone, that has to be still led internally by the leader.
Yes.
Because yes, we need you to go and talk to our operations and tell them what we want to tell them. But in the end, me and my team, who is responsible for running that operation, has to make that connection, has to make that relationship. One last thing I'll say on this is, what do we really highlight in front of the organization? They don't want to hear, probably they want to hear that we have covered all the vulnerabilities, all the highs are being addressed, we have a process going. But I think one metrics which I found very powerful to present is, how are our people doing? Because they are the weakest link in this chain. And one metrics again, one of the metrics is how well they are doing in terms of our various phishing exercises. And I have seen that move in a very significant manner. When I did a baseline test 2 years ago, about 13% of our users were clicking on those phishing emails. Today, it's at 2%. So it's a sustained effort, but that is one thing which leadership needs to, and that didn't happen on its own. It happened with the leadership alignment, and that's what we made it a priority for the organization that you need to pay attention to cybersecurity. You need to go through the training. If you click too often, then you will call to principal's office. All those things eventually led to this. Nobody considered it can again spike to 7%, 10%. So I think the metrics which organization needs to know, how are people doing, and we need to give them confidence that we got all the technology and technical aspect of it covered.
So I love the idea that it sounds like we're all, does anybody want to disagree with the idea that it's inevitable? Because we could put that to a side.
Nobody can dare to say that.
It's like, so, and I say this only because up until maybe 2 years ago, in all of the government work that we were doing, and governments have as big as your budget is at your entire hospital is their cybersecurity budget, right? So in their cases, they were of the belief that a breach is not inevitable, right? And if you believe that the breach is not inevitable, then you organize around that thinking, right? And that's why I want to just make sure everybody from the audience hears that loudly and clearly,
Yeah.
so that when your CIO or the CISO comes to you and says, here's what we have to prepare for after the breach, you don't say, why would we have a breach, right? I mean, it's a silly question to ask. So having put that on the side now, what I'd love for Robin, maybe Pam, to talk about is, what are the metrics that tell you that you are prepared? And then you guys can critique what they say again, which is, if we come in and we say, and Pam, I love what you talked about as far as organizational structure, making sure that everybody's prepared with appropriate steps and things like that. But maybe talk, Rob, about what are the metrics that you see that you would suggest to maybe our CIOs on the panel to say this might tell you whether you're ready for access management or zero trust, et cetera.
Yeah.
And then Pam, you could tell us what are the metrics that we could use to say the people are ready on a post breach, not whether or not the breach will be covered. We're all going to try to do our best to make sure things don't get through the firewall, but they're going to get through. And so what are the metrics that tell us that we're prepared?
Yeah. So on the government comment, my data was lost by government breach. So come on. Like, it's anyway.
Yeah.
The
By the way, that was a classified, cleared professionals database. Like those of us who have had clearance in the past, that database where the FBI does all the investigations, stores everything super secretly, super securely at the OPM, the Office of Personnel Management. That's the database that was breached. Right. So not a simple database like in Microsoft Excel file.
Right.
Go ahead, Rob.
Yeah. So anyway, the metrics vary quite a bit, organizational, like it depends on what's going to be important, right? But when you start to assess how ready you are for, let's call it some organizational change in terms of your approach, we
Is that a euphemistic way of saying the breach?
No, well, look, the breach could absolutely be the catalyst to that change, right? We see this all the time, right? And you can subtract, the company that I work for out of this. When you look at cyber across the board, there's a few different drivers, right? Oftentimes it's a breach. It's, hey, something bad happened. We've got to call in the cavalry. We've got to do the work. And now we all of a sudden, magically, we have funding that we were told we didn't have before, and we go change a bunch of things, right? Another one is audit findings, right? There is so much, and I'm just in the state of New York, the things that are going on it's awesome. I like to see the new things coming about. But if you look at what happened last year, I think it was commented already, that 2024 was a testament to what can really go wrong when breaches happen, right? Those things, again, audit findings, tend to bring budget. There's oftentimes transformational efforts going on. Again, as we talk about the adoption of SaaS and cloud, we see big ERP transformations, we see EMR transformations, we see all of these types of things that change fundamentally how your organization thinks and ticks and integrates. And it's with those that you uncover some of the greatest risk, and then hopefully you identify and start to apply, process, technology, continuity, operations, whatever, to solutioning them, right? So, from a metric perspective, we're always paying attention to, like vulnerability scanning is a great thing. You have an understanding of, legacy systems, you have an understanding of what's there. But what's really complicated in my world is the mass amount of merger and acquisition that's happening in healthcare. And back to the whole, it's a matter of when, not if. If you're merging with an organization, whoever the acquiring organization is, if you're doing doing this a smart way, you're going to assume the company you bought has already been breached, and you're going to work your way backwards, because you can't just add a trust and assume they did everything right. So we have a lot to do in that space.
So if you think about just the identity and access management, couldn't there be, like, the issue of anomaly detection is one of our principal concerns these days. Is anomaly detection is fine. You have to know what the anomaly is. What if we said that pure access management would be a metric, is to know total number of users, how many were eliminated, how many came up again, what amount of access was growing or shrinking? What are some ideas that maybe people could use to think about just at the IAM level, identity and access management, around metrics, and to try to detect the anomalies? Because wouldn't those help us predict potentially where some of the soft spots were, where breaches are most likely to occur?
Absolutely. So it's a personal story. So my daughter, when she was 19, moved out of pediatric care into primary care, and she moved one health system to another. Okay, so I went with her on that appointment, and I helped her fill out the paperwork, and all I was going to do is just hand her off, right? So the nurse comes up, collects the paperwork, she takes one look, and she says, "Oh, I used to work there. I still have a login. I'll just go get your records," right? I mean, it's just mind-blowing, right? So let's be clear. Terminations are a thing, right? People move, people change, and third-party risk has drastically accelerated since the influx of travel nursing and the number of contract physicians, et cetera. So having an understanding of those metrics and those life cycle events, and really candidly, making sure you're auditing those is super important, right? So if you have someone who's on a contract in your organization, they've been sponsored in, they've hired, if they leave 2 weeks later, what mechanism is happening to say, oh, we've terminated their access? And I bet if you go ask internally that question, you're going to get a different answer from a bunch of people.
Yep.
Right. And this is too risky. Right. So we look at that type of stuff.
Was there a question? Yeah, please.
Kind of it goes back to the whole, like, did we make the process easy or hard?
Correct.
So we probably made it really hard for the nurse manager who said this employee is leaving my department, but I have to now go sit down and put in a ticket and 400 requests later to, like, we have to be able to automate those processes to say the nurse now no longer works in that department and works in a different department. And then there needs to be some kind of ritual, whether it's quarterly, annually, that you're evaluating. Hey, you're supposed to have 50 FTEs. These are the people, this is the access, this is what they have. We need to validate it. Validate with the employee as well as validate with the managers, et cetera. But we have to get to that kind of rigor. And back to your point, it has to be, everybody has to be all in. It's not cyber's, responsibility. Everyone has to own that and be a part of that.
Great point.
I can
Yeah.
chime in there. This is the reason this is the way it is, because it's manual. No automation can happen on its own. There has to be a manual trigger for a transfer of an employee. And this problem is actually multi-fold for all third-party users. This problem is better for your full-time employees because there is an HR process in there. It's a third-party users where you don't have an HR process. And this is, I wish there is a real technology to solve it, but I've been living this for years. It is really manual. You can tighten up your process. You can do the audit quarterly. Probably isn't. We don't have resources to do that kind of audit, but there has to be a process where we don't leave access for a nurse for 3 weeks. But the problem is, it's really the hiring manager or the HR manager who has to initiate that. And yes, you can think about various way of automation, but people need to start doing this role. And I want to add another point. You talked about anomaly detection, right? There are various tools. We can do the anomaly detection. We can do what you recommended in terms of, kind of identity metrics, right? How many people have been provisioned, how many, but in the end, for a large organization, that's too much data, and all we'll have in the end is a data. So we need to figure out a way to create that data into insights, which make us more secure. And that's a challenge. I don't think there's an easy solution. So that's where probably now there is a promise of various ways of a technology bubbling to top what you need to address versus ignore the 900 lines. These 20 are more important.
Great point. And so, Pam, if you can just jump in and tell us then, assuming a breach, what are some metrics, KPIs, the techniques that people can say we are ready for post-breach?
Yeah, so a couple of things. When I worked at a recent organization, I thought the CIO and the team did a really fantastic job, and I was part of the process. We're doing their business continuity program, and a couple of things we looked at was really for us when I talked about business continuity program. I was actually looking back and thinking, I was just jotting down things, and I thought, okay, first thing was recovery time objective. I look at the business impact analysis. Based on your tier 1, tier 2 applications, how quickly do we need to restore some of these functions to be back to use? Mm-hmm. And can they be available fast enough, right? So we think about that from that particular perspective I think about recovery time for objective. And then the recovery point objective for me is what is the maximum acceptable amount of data that is lost that we can accept? Right? Because when you back up the systems, you usually have a lag process when you have that. And so how far back does that go when you restore that data? How much data do we need to in there, like minimum viable data in order for you to keep the operations running? I also look at, and I thought about things like in the business impact, and I look training. How well prepared are people trained? And in cases when you have an unplanned downtime, one of the emergency responses we had was on-call schedules that when you're having unplanned downtime, people have to focus on the patient. So then there is a backup plan for who are some of the per diem or users we can always have on call to come in to help do the recovery. So that's part of the incident response plan for what we call P1s. And you have a HICS command center that exists in the hospital. Is that available? Where is that? You look at downtime recovery policy and procedures. Is there a central point you store? What happens if the network is down and you don't even have access to power? Where are you going to get that information? So there's different scenarios like network is down, power is out. This is what's going to do. Network's on, but your EMR is down. What are you going to do? So there's like different scenarios that is stored, and those are part of some of the tabletop exercises you measure. Then you go into a piece. Our training team developed a proficiency test. So every user, every IT department users, like 100% compliance was what the CEO wanted with the CIO. Like, we will get 100% compliance unless you're on leave of absence, FMLA, that sort of stuff, right? So what they do is they go through the training program. There's a proficiency test that the training team worked on with the CISO group and the business analyst from the IT team. They create the proficiency exam, a little bit different from the analyst versus the operations group. When you go through that, if you have a fail rate of less than 80%, you have to go back to the training sessions. This is a program they put into place. And everybody is mandated to go through 4 times a year of these tabletop exercises. And as part of their HR evaluation, they roll it up as part of their incentive program, that you understand what downtime means. And there is a survey that goes out annually before the performance reviews are due that actually measures your proficiency. And it's just a set of questions. What are the different types of downtimes that you will experience? When this happens, what is the correct answer? So it's like multiple choice questions that they go through that particular process. So when we go through that, it was a set of like 10 scorecard metrics. They're not all weighted the same, but it has different weights to those components. That's what they kind of use. It goes actually in front of the CEO at their committee called SMART Committee, Strategic Management Action Results Team is what they called it. And every quarter they do the board meeting. That dashboard actually goes to the board meeting level to let people know how prepared we are or not prepared we are, and where are the areas we need to do a little bit more work. And so that to me was a very comprehensive program which retained metrics of success for the organization they thought would be good measures. B, they also showed about a 7-page security risk assessment, and they dumbed it down, if you will, to like a 2-slide deck on this is why we need everybody's responsibility to be about security. It is all of our responsibility, right? Followed by testing. I thought it was a really great program that they worked together on with us, and I enjoyed working with them on it.
Yeah, that's great. And we'll take this question here, but the 2 key things to think about as part of this conversation is 1, inevitability, 2, business continuity, and post-breach or post-phishing success, meaning somebody phished you successfully, is not the same. So again, business continuity and being prepared for being locked out of your data are not the same thing. And so that's why it's so important to have these. I love the decision tree, like you know which one is causing this, and that's why you go down that path. And until we get to the inevitability and understand that a post-breach, post-phishing attack is not the same as BC, I think we're gonna have to redo some of our workloads there.
I want to make one point here. Pam brought up recovery time objective, recovery point objective. Will seem like a very academic exercise when you're doing it, but think about it. When you are in a situation and you may not waste resources if it's past RP or RTO, because resources are hard to come by at that time, and speed is a key. So these things are very hard to do initially, but this is what really helps you prioritize when you're in the middle of a situation.
Great point, Michael.
Yeah, I have a question for the panel. I think you guys have made leaps and bounds over the years. I do phishing exercises every week. There's downtime exercises. I think employees and employers are doing a good job, but my growing worry is that our patients are becoming more digital. And I have 70,000 employees, but I have 7 million patients. So that's a 100 times more probability that they're going to let somebody in. Because I read about grandma giving their life savings to a scammer in Asia every single week. And they just, I thought it was my healthcare system. My doctor was reaching out. So what are we doing to educate the patients and protect ourselves from the patients? And then preemptive downtime, what do we tell the patients? Not in the moment, but hey, 2 weeks from now, 10 weeks from now, we might go down. This is what you have to do so you can get access to healthcare if we're in that state. Is there anything being done on the patient side to educate and protect them?
So I'll pick up on this. So to answer your last question first, we don't have a mechanism of informing patients of a planned downtime. Hasn't gotten to that point yet. But a good point to consider as we roll out more and more technology to patients. Essentially we are going where travel industry went years ago. We're asking them to do the work, right? So if you're gonna ask them to self-schedule, then we better inform them our system will be down for 2 hours for maintenance. So that's never gonna fly in any health system. Okay, so but that's different. So two points to this. You cannot really control the environment, and that is where all the digital initiatives have created a challenge for all of us. We in healthcare have been so used to working in a controlled environment. We can observe the clinician's workflow, design a system, launch it, train it, manage it. We do not have that control when it's up to the patient. So then you're gonna work on a lowest common denominator. The concept of zero trust comes in at all levels. Access to information, what they absolutely need, and secure it at your parameter, not relying on a patient's parameter.
I think the only thing I would add to that, and this is certainly giving me ideas as I go back as well, thinking about that from a business continuity perspective, because when all else fails, someone will pick up the phone and call. So how you're preparing your contact centers, what their processes need to be, I think are going to be key, because, whereas I might say, well, I'm not going to book my flight. I'll wait a few days till whatever is going on gets solved. If I'm sick, I want help immediately. So I think there will be an urgency in those scenarios. So that front line with patient access and contact centers, I think is probably a key place to drill down.
Yeah.
The one thing I was going to add to that too is, one of the services we do, this is a good question. It's very timing, actually. We work with a couple of clients, and one of the recent one is we do their call center, we do their patient service desk. And so as part of that, we interact with the patients, and we have like a bi-directional, right? We have the inbound calls where patients call us and we're answering their questions, but we also do outreach, patient outreach as part of our program. And so we do patient outreach because we're looking in their My Chart and we're finding out they didn't have to follow through. So we work with their communication department to kind of do that. So one thing they actually talked about us, the CIO came to us and said, Pam, in terms of the patient service desk, what do you think is a good recommendation for us? We need to prepare if something happens and the system goes down and they can't show up for appointment, or we need to delay, what do we do? So we just started drafting up different scenario scripts with the communications department for the organization, the clinicians, and all them to approve. But the synopsis is, if that actually happened, they would say, we would need your staff in the call center and your team to do the patient outreaches. And we'll probably assign some people to man just traditional phone call and just call anybody, like print out the list of patients that have schedules and just reach out and start calling them and communicating to them. We'll script it to not cause panic, keep confidence, be poised. So I need your team to dry run with us and make sure you can stay poised and you can handle that type of conversation. So in their mind, they're like, you're going to be my patient outreach, and you're going to reach out to them through the call center stuff and get a list and work with our clinicians, and we'll start calling these patients. So to your point, Steph, that's right. We would just do the traditional phone call, and kind of just call each person, make sure we have that high touch in that particular moment, and even walk them through a scripting. Probably is what we'll do, is like, here's how you can get your information. We're going to call you back on X date and we'll reschedule you. So those are some of the scenarios we kind of talk through. But I thought that was good. And I wanted to hit on something that you mentioned I thought was really good. One of the things the customer we worked with that I shared the scorecard on, what I really love about their tabletop exercises. And remember, we said when unplanned things happen, it does happen. It did happen for them once. They go back to lessons learned, and they said, based on our scorecard, how fast did it take for us to recovery? How well did we do in this scenario? And even with the tabletop exercises, they even calculate that. I love their iterative lessons learned. How do we apply that? Are we as good as we think? Do we need to adjust the scorecard? And it was interesting because I remember the CEO and CIO saying, we're not moving the target because we didn't hit it. The target is the target.
Yep.
We're going to work towards hitting that target, even if it means we got to do this 10 more times. And I really think you guys have such a great change management, philosophy behind things. But I just want to share that because I really think they did a fantastic job.
That's a great anecdote. In fact, we only have about a minute left, so we'll take the last question here.
Here is I'm taking advantage of the whole AI technology innovation that's occurring right now, and I'm creating a startup like so many other physicians. I went to the JP Morgan events last week, and it was crazy, all the new companies that are forming. So I'm forming a startup, and I'd like to know how or who do I speak to make sure my company is immune from a breach. What do I do? You were mentioning either cloud-based or SaaS-based. How do you make that decision, and who do I speak to?
We'll let the CIOs
Yeah.
answer that because you're going to have to sell to them. So
So I would answer in certain way, right? You can go any kind of architecture, cloud or SaaS. If I am evaluating a vendor, I want to do my entire cybersecurity HIPAA risk assessment for a vendor. Increasingly, most vendors comply these days. They all get SOC 2 certification, HITRA certification, because no healthcare system will touch them or even be able to sign a contract. So that's what I would say is table stakes now to have a secure platform for you to offer services.
And basically, it's a good summary is that there are certifications. Just start with SOC 2 Type 1 and then move to SOC 2 Type 2. And if you can't do that, you can grab one of us after the meeting and we'll lay those out. Because if you can't do SOC 2 Type 1 or Type 2, you should just get out of business. I mean, just stop your company, do something that's easier to do. Now, inevitability within hospitals and health systems is something that is sellable. You on the startup end and the vendor end cannot sell that breaches are inevitable, right? You have to somehow be able to prove that your breach is not inevitable, even though at the hospital, they assume that the breach is inevitable.
Unless as a physician, you tell us, how can I stop aging?
That's a great point. Well, with that, I know we're running a couple minutes late, so a big round of applause to our panelists here. And remember that all the panelists, they'll be around. You can ask them questions, and they should ask questions of the upcoming panelists as well, and vice versa, like we're continuing this conversation. So fantastic. Thanks, guys.